Assalamu alaikum. Hello, everybody. I hope you're having a good time and enjoying the conference so far. I'm not sure if any of my professors or colleagues from Ain Shams University are present in the audience today, but if they are, I would just like to send my best wishes and regards, especially to the lovely Professor Galila and Professor Tawhid Abdel Ghaffar, and hopefully I will see you next year in person. My talk today is on liver disease or liver involvement in systemic diseases. And this is a huge topic to cover just in one talk. But what I will try to focus on will be the essentially why and how the liver is involved in systemic conditions, the principles of investigating liver disease in context of systemic problems, and an overview on the management. As a hepatologist, I always say the liver is the most important organ in the body. And certainly it is the largest solid organ, weighing around 300 grams in a 10 kilograms baby. Each gram contains millions of hepatocytes arranged in subunits called acini. Each acinus is composed of endothelium lining the blood vessels, sinusoids, epithelial cells, whether it's hepatocytes or cholangiocytes, and mesenchymal cells, both immune cells and stellate cells, which produce the collagen when they are activated. Next. The liver is privileged by having dual blood supply from the celiac axis through the hepatic artery and through the portal vein. And this is to enable it to perform its complex metabolic functions. Although the hepatocyte cell mass is regarded as a single entity, the function of hepatocytes are differentiated along the pathway of the blood supply from when the blood enters into the portal tract till it leaves through the hepatic veins. Next. And as you can see from this diagram that hepatocytes arranged in zone 1 near the portal tract are closely involved with biliary structures and with immune phenomena, and that's where we find the changes on histology, for example, in inflammatory bowel disease and other immune disorders. Whereas the cells in zone 3, furthest away from blood supply around the central vein, are more responsible for detoxification and are rich in glutathione. And that's why, for example, in cases of paracetamol toxicity, we find the damage or the changes on histology are more prominent in zone 3. So it is important to understand this structure if we're using histology to help us or aid us in the diagnosis of liver involvement. Next, please. So the target tissues in the liver that will be affected in any disease are the bile ducts, hepatocytes, and endothelium. Next. And the blood tests will reflect that. So for example, if the bile ducts are the major site of injury, we will find high bilirubin, high gamma-GT, and alkaline phosphatase. Whereas if the hepatocyte necrosis is the predominant feature, they're mainly elevated of the transaminases and impairment of the synthetic function of the liver, coagulopathy, low albumin, and hypoglycemia. Endothelial damage will be manifested with slight rise in transaminitis, but also fluid overload, ascites, etc. Next, please. And just quickly to understand the interpretation of the blood tests or liver function tests, the transaminases are responsible for amino acid catabolism and permitting them to enter the citric acid cycle. But the AST has a shorter half-life. So we find that the AST will peak before the ALT in the liver diseases. But although the ALT has a delayed peak, it's more specific because AST is found in cardiac, in skeletal muscles, kidney, and brain, so it's not as specific as the ALT. Alkaline phosphatase is stimulated by cholestasis and accumulation of bile salts. It will stimulate release of alkaline phosphatase, and that's why in cholestatic conditions, it starts to rise. Because it requires zinc and dependent on copper metabolism, in cases of Wilson disease, for example, we find that alkaline phosphatase is rather low. Gamma-GT is another marker of cholestasis. Its activity is also influenced by other drugs, so it can be elevated in cases of children using anticonvulsants or oral contraceptives. And finally, the bilirubin, we look at the conjugated fraction because it's another indication of biliary obstruction, but also a very good marker in cases of fibrosis, cirrhosis, and sepsis. Next, please. The organs that can affect liver, any disease in circulatory, gastrointestinal, hematological, immune, and multi-system disorders. Next, please. The multi-system disorders are many, for example, granulomatous diseases, malnutrition and obesity, and I've covered the role of or the effect of obesity in my talk on NAFLD previously, sepsis, and hormonal disorders. Next. So I'll start by circulation. Next. Any disturbance in the circulatory function, whether it's congestion, hypoxia, or low cardiac output, will all cause liver damage. And I will explain in later slides. Next. The hepatic veins drain into the inferior vena cava or directly into the right atrium. So any increase in the right atrial or ventricular pressure, as in cases of constrictive pericarditis, pulmonary atresia, Fallot's, or post-Fontan procedures, this will cause congestion on the liver with sinusoidal engorgement, and this is reflected by abnormal transaminases usually, and the alkaline phosphatase bilirubin generally are normal. There is a large tender liver, protein-losing enteropathy, ascites, and eventually cirrhosis. We see in our clinics children, or rather teenagers, post-Fontan for many years, and they start to present with cirrhosis of the liver. Histologically, next. Histologically, you will find the characteristic sinusoidal dilatation on the liver biopsy, which diagnose the congestion of the liver. Next. Cases of hypoxia, for example, severe neonatal asphyxia, which does not only affect liver, but also the renal and CNS function in most cases. Another example in seizures, although the cases of seizures and liver involvement usually multifactorial. So it's not only the hypoxia from the seizures, but the effect of the anticonvulsants will have a role. The underlying condition that caused the seizures might have a role. And commonly, the children who are having cardiac surgery, if the bypass is prolonged and there is a significant period of hypoxia. Characteristically, zone 3, which is furthest away from the blood supply, will be the most damaged. There is always a sharp rise in transaminases in thousands, quite scary numbers really, and it occurs not immediately after the insult, but within the first 24 to 48 hours after the insult, you'll find the peak of the transaminases. This is followed by cholestasis. Prognosis of liver dysfunction is generally good, provided that the normal circulation and gas exchange is restored and returned to normal within a short period of time. Next. Low cardiac output in case of hypoplastic left heart, cardiomyopathy, fetal arrhythmia, again will obviously reduce the blood flow to the parenchyma, and zone 3 will be the most affected as well. But the most sensitive part of the liver to ischemia are the bile ducts and the bile tree. And as we can see from this diagram of PTC or percutaneous transhepatic angiogram, the hepatic duct obstruction or narrowing in cases of prolonged ischemia, which we see also in hepatic artery thrombosis, whether in a native or transplanted liver. And usually there is cholestasis in these conditions. Next. So the treatment essentially is to treat the underlying cardiac disease and support the cholestasis by ursodeoxycholic acid, fat-soluble vitamins, and medium-chain triglyceride feeds. Next. Another system which is closely linked to the liver is the GI tract. Next. Next. Sorry, can you go to the previous slide? Inflammatory bowel disease, all types of inflammatory bowel disease, whether Crohn's, ulcerative colitis, indeterminate colitis, they're all associated with liver disease. In cases of celiac disease, there is a parallel inflammatory process occurring in the gut and in the liver. Also, we see liver involvement in the intestinal failure, associated liver disease, and cases of cystic fibrosis. Next. IBD is the most common condition, GI condition that we see, and it is associated with liver disease. And we're constantly in contact with our gastroenterology colleagues, referring us children with IBD and abnormal liver functions. And this is because of the close anatomical connection between the gut and the liver via the portal vein, and the abnormal microbiome that's present in IBD and can be translocated to liver. Another reason is the abnormal permeability of the intestinal mucosa, allowing ingress of pathological antigens and stimulation pro-inflammatory cytokines. In IBD also, in some cases that require surgery, especially in the terminal ileum, there will be impaired intrahepatic circulation. Another factor is the drug-induced liver disease by azathioprine, which is commonly used in IBD, or even the infliximab. There are studies now that shows the infliximab can cause liver damage. Another reason is infection in the immune-suppressed patients or flaring of a pre-existing viral infection, like children who have chronic hepatitis B. Next. So liver functions are usually elevated, mainly transaminases, and in about a third of the cases, this is transient at the onset of the disease. However, if this transaminases or abnormal liver functions persists more than 3 months, they require referral for an assessment and a liver biopsy to diagnose autoimmune liver disease. Another very useful investigation is the MRI cholangiogram, which is recommended if there are abnormal LFTs in children with IBD, because it can pick up early biliary changes and early sclerosing cholangitis. Management is usually the ursodeoxycholic acid, controlling the IBD. And if we believe that this is drug-induced, is to reduce the drug dose or even withdraw the drug altogether if possible, like the azathioprine, and replace it with another drug. And TPMT testing could be useful before initiating azathioprine. Next. What about hematological disorders and the liver? Again, with our hematology oncology colleagues, we work very closely and we get a lot of referrals from them. Next. Again, a lot of hematological disorders present with liver disease, so hemoglobinopathies. Majority will have bone bladder stones and recurrent cholecystitis. Hemosiderosis and iron overload can be seen very early on, really, even after few blood transfusion. We can demonstrate iron-laden macrophages, but the clinical presentation or clinical significance is manifested after 10 or 20 transfusions. The iron overload can result in liver cirrhosis if bone marrow transplant is not done before this stage. And a very good way of monitoring iron overload now is by MRI. We don't need to do liver biopsies to monitor hemosiderosis. The ferry scans are a very good method of detecting iron and quantification of iron. What about bone marrow transplant? Again, many conditions can affect the liver. The veno-occlusive disease, or more accurately sinusoidal obstruction syndrome, graft versus host disease, and the direct effect of the cytotoxic drugs. And I will talk about this on later slides. Another hematological condition is HLH, or hemophagocytic lymphohistiocytosis. Next. Sinusoidal obstruction syndrome is seen in about a third of the patients undergoing bone marrow transplant. And it's more, the population at risk or children at risk who had radiotherapy before the transplant or with certain conditioning like the busulfan. And it represents Budd-Chiari syndrome, where there is hepatomegaly, increased hepatic resistance, and retrograde flow on the portal vein. Next. The other condition is graft versus host disease, where there is failure to establish tolerance between the recipient tissue and the grafted marrow. So the grafted marrow is attacking the recipient tissue, and it can be acute within the first 1 or 2 months, or it can be chronic, manifested more after 3 months of the transplant. And it does not only affect the liver, but the skin, the gut, the lungs, eyes, but liver is involved in 40% of the cases of GVHD. Next. So how can we manage, or what will be the investigation strategy when we get a referral from our colleagues in hematology oncology following post-bone marrow transplant? Child unwell with abnormal liver function and usually cholestasis, which will present in all of these cases, but also can be a manifestation of sepsis, fungal sepsis. They are quite sick and immune suppressed children. With GVHD, you will always find other clinical criteria, mainly skin rashes and diarrhea because of involvement of other organs. In the SOS, it is a picture similar to Budd-Chiari, where we have large tender liver, ascites, elevated jugular venous pressure. As the majority will be cholestatic, it's difficult to sometimes to distinguish, and ideally we would like a liver biopsy if the condition and the coagulopathy allows. And characteristically, there is bile duct involvement in the cases of GVHD, with complete loss of bile duct in the chronic cases, as you can see from the slide at the corner. Whereas with the SOS, there will be narrow or occluded vessels characteristically. Treatment of GVHD is by immune suppression, by steroids, tacrolimus, and extracorporeal plasmapheresis, ECP, in the resistant cases. Whereas in SOS, we treat the fluid overload by giving diuretics, treating cholestasis, and defibrotide as a thrombolytic, especially in the high-risk group. Next. Another hematological condition commonly we see commonly in referred to us with liver dysfunction is the HLH, and it's either primary or familial or genetics, where there is a family history of HLH. It is autosomal recessive in most of the cases, or secondary to sepsis. And that's when it becomes difficult or challenging to diagnose whether this is HLH or just sepsis. And therefore, that's why there are criteria to guide the diagnosis of HLH, and there are 5 out of 8 of these criteria. It is sort of pushing more towards HLH diagnosis, like fever, splenomegaly, cytopenia affecting 2 cell lines, low hemoglobin, low platelets, low neutrophils, hypertriglyceridemia, hypofibrogenemia, and hyperferritinemia. But obviously, if we can demonstrate the hemophagocyte cells in the biopsy, bone marrow biopsy, that would be diagnostic, and also the elevated IL-2 receptor, or CD25, depending on the turnover and how long it takes to get this result back. Next. The main challenge in diagnosing these children, as I said, is the uncertainty. They have hepatosplenomegaly, jaundice, but they are very sick children, and they go into fulminant liver failure very quickly. Therefore, establishing a diagnosis is crucial, and involving hematology colleagues earlier on if we suspect this condition, because bone marrow biopsy may help. Next. Immune dysfunction. Any immune dysfunction will also result in liver dysfunction. Next slide, please. Whether genetic or primary immune dysfunction, like SCID or hyper IgM syndrome, CG4 ligand deficiency, chronic granulomatous disease, all spectrum of primary liver immune dysfunction will be associated with liver disease. And the same with acquired, like in the HIV infection. Next. The majority will have abnormal liver function tests, but characteristically, because of the immune suppressed patients and the recurrent infections, they are prone to cryptosporidium infection, which results in sclerosing cholangitis. HIV can cause hepatitis, especially if there is a co-infection with hepatitis B or C. And in some cases, the immune dysfunction results in non-cirrhotic portal hypertension as a result of non-general hyperplasia or portal obliteration. Next. This is just an ERCP showing the cholangiopathy in a case of a child with immune suppression and cryptosporidium cholangitis. So it's very important to look for cryptosporidium aggressively in cases with liver dysfunction, jaundice associated with immune deficiency. Next. What about multi-system disorders? What are the multi-system disorders? Next. Chronic granulomatous disorders. This could be quite challenging. And as you can see from the slide, it's quite busy, but it's just to demonstrate the various granulomatous diseases and that all of them are associated with liver dysfunction. They're all multi-system, and some of them may have characteristic features like in tuberculosis and demonstrating a caseating granuloma, if it's that simple, but if it's possible, it will be easy to diagnose. Sarcoidosis is quite challenging, and we can find elevated ACE levels or angiotensin converting enzyme levels, but not in all cases. So it can be quite tricky, and there is always a delayed diagnosis, but we have to have a suspicion if there are other areas involved, especially the lung. Chronic granulomatous disease, another immune deficiency condition and a granulomatous disorder, and it's manifesting as multiple liver abscesses. So investigating, they may present with liver disease as a primary disorder, but in the majority of cases, there will be other organs involved. So this will help us to try and guide us towards the investigations we need to do. Next. Another multi-system condition, which is not common, but we've seen few in the liver unit as well, is Langerhans cell histiocytosis, which is a, again, multi-organ or multi-system, and the presentation depends on the organ affected. So if it's pituitary, diabetes insipidus, or liver, or skin, and in the liver presentation is mainly cholestasis and hepatomegaly. And in few cases, biliary obstruction ending with biliary cirrhosis were reported. Liver biopsy will show liver involvement, mainly in the biliary system, and eosinophilic granulomatous. The prognosis is variable, and it's worse if we have multi-system involved or if one of these systems are severely involved. So when it comes to liver transplant, the decision is quite challenging because it's a multi-system, and if we save the liver, there are still the risk of progression of the other organs. Next, please. Other multi-system problems, endocrine, whether too low of the hormone, like hypopituitarism, hypothyroidism, or too much in cases McKeown Albright. Next, please. The most common cause or multi-system cause for liver dysfunction that we come across is sepsis. And cholestasis results as an effect of the endotoxin on the bilirubin transmembrane carriers. And that's why we see cholestasis early on. Also, in quite sick children, there is hyperperfusion, ischemia, and as we discussed before, ischemic effect on the hepatocytes and necrosis with very high transaminases. In staph sepsis, it can present with micro abscesses in the liver. Recurrent sepsis in immune-suppressed patients or recurrent causes of sepsis can end up in hepatic fibrosis. The characteristic findings in ultrasound is what we call starry liver or a bright liver, and sometimes acute hydrops of the gallbladder can be demonstrated. Next. Recently, we are amidst the pandemic of COVID, and there have been studies looking at COVID and the liver. Overall, with COVID, infected children appear to have milder disease course than adults. And in the few studies that looked at pediatric patients, there were only few who had elevated liver enzymes. Even studies that looked at newborns to mothers who had COVID pneumonia reported very few cases of abnormal liver function tests in the neonates. Next. And the proposed mechanism of injury of the liver in the context of COVID is either direct cytopathic effect on the hepatocytes or the cholangiocytes, uncontrolled immune response by the cytokine storm effect, drug-related injury, ischemia, again, and hypoxia if the patient is very sick and hypoxic, or if the patient has an existing liver disease, pre-existing liver or chronic liver disease. Next. So the direct cytopathic effect is because, as we all know, that the SARS-CoV-2 receptors are the ACE2 receptors, or angiotensin-converting enzyme 2 receptors. And studies have demonstrated the presence of these receptors in 3% of hepatocytes and up to 60% of cholangiocytes. So they are both a target for the COVID and specifically the cholangiocytes. Next. As part of the cytokine storm or the uncontrolled immune response, it is proposed that liver gets affected. And that's because studies has shown higher pro-inflammatory cytokines and chemokines in patients with COVID who had abnormal liver function tests compared to patients with COVID and normal liver function tests. Higher levels specifically of the IL-2 and IL-6 in those patients. Next. Other mechanisms of injuries, as I've mentioned before, drug-related, the new antivirals that are trialed now for COVID, the antibiotics, all this will have a compound effect. Patients who have pre-existing liver disease, the COVID will worsen the underlying condition and will contribute to acute on top of chronic decompensation. It will also aggravate cholestasis in patients who have mainly biliary problems. Next. So what we find in patients with COVID, mainly elevated transaminases in maybe around 30% of patients, but as I mentioned in pediatrics is lower than that. It is not correlated to disease severity, so not necessarily patients with severe COVID will have higher ALT or AST. But we found that the abnormal liver function is higher in ICU patients, which is expected because probably the other cofactors like hypoxia or drugs and etc. They also present with cholestasis because, as I mentioned, they target the cholangiocyte, but very rarely acute liver failure cases were reported. Next. Histologically, it's not characteristic, not specific changes with COVID, and the few cases of post-mortem, when they looked at the liver, there are variable changes, whether microvesicular steatosis, some of them had lobular or portal inflammation, sinusoidal dilatation, so quite varied and not specific, really. Next. Patients who are on COVID and immune-suppressed liver patients, so either patients with autoimmune hepatitis or post-liver transplant, As we would expect, because of suppression, the immune suppressive drugs suppress both the innate and the adaptive immunity. Generally, what we see, there is a more severe illness. For example, if they had any viral illness or flu, influenza virus, it is expected to be more severe in immune suppressed cases. However, with the COVID, it was found not the case. And patients with autoimmune liver disease did not have any more severe disease, and similarly with post-liver transplant. This is probably explained because part of the pathology in COVID, as you know, is this immune response, the host immune response to the virus. So if the host's immune is suppressed, it probably is in favor. So we haven't seen any severe cases in our post-transplant patients. Next. So just briefly, an overview on the management of liver disease and systemic disorders. I've already mentioned along the way the management of each condition, but overall is to treat the underlying cause if possible. Another important thing to try and bear in mind is to avoid contributing factors like drugs that might worsen the liver condition, protect against infections if possible. More importantly with liver disease is nutrition, and enteral nutrition rather than parenteral nutrition whenever possible. Treat cholestasis and support liver failure if required, and refer to liver transplantation. Next. So in summary, the liver is exposed to a wide range of agents liable to disturb its function. The volume of the blood flowing through the liver and its complex function means that systemic diseases and systemic illnesses in other parts of the body frequently affect the liver. Liver biopsy is not without its risks, but when there is diagnostic uncertainty, it's important to get the accurate information. Presence of granulomas should prompt thorough investigation and to evaluate for immune deficiency and sarcoidosis. Nutritional supportive therapy is the mainstay for managing liver disease. So I hope I managed to pass the information adequately, because some of the slides were rushed, but as I mentioned, it's a very long and dense topic, but any other questions, it will be open in the Q&A sessions, and hopefully I can answer any questions. Thank you.
Thank you very much, Professor Murtada Shabrawi, for this very kind invitation. Sincere apologies that I was not able to make the amended conference date and to be with you in person, but I hope I'll be able to convey the message virtually. The first talk I am going to cover today is about fetal programming and the fetal epigenome. This is an image of a boy. As you can see, this boy is very undernourished. And this is at the time of the Dutch famine, the famine that has happened in the Netherlands, in Holland, around the time of the Second World War. In fact, I don't want you to look at this boy. I want you to look at the woman standing in the far distance in this image, carrying a baby. Because one of the issues that happened around the Dutch famine were women who were pregnant were very undernourished because they themselves were doing a lot of exercise every day on their bikes, trying to get food for the family. Obviously, they would stop themselves from eating to feed the family. So their caloric intake every day was really very minimal. Some of these women obviously were pregnant, and when they delivered very small babies. A lot of these babies eventually did fine, and they seemed to be okay and developed, and they became adult men and women. But what was observed 40 or 50 years after this is that this cohort of babies who were born small around the time of the Dutch famine started getting diseases at a higher rate than the normal population. These diseases were in the form of heart disease, hypertension, diabetes. And because of this observation, this has led to the concept of fetal programming. This observation was first done by Professor Barker, and hence it's called the Barker's hypothesis. And in the Barker's hypothesis, it is believed that the level of nutrition and endocrine status around the developing fetus result in some developmental adaptations that permanently, and it's important to underline the word permanently, change the structure and the physiology as well as the metabolism of that fetus, particularly its organs. This change seems to be the predisposing factors for these individuals developing the diseases I mentioned previously: cardiovascular diseases, metabolic disorders, as well as endocrine disorders that do not seem to manifest themselves till later on in life. So this concept, which now people believe that some maternal dietary changes or intakes can have an impact on the fetal genome, our genes, as we are developing as fetuses. And this combination of events is what is actually called fetal programming. There is no doubt that our understanding of the human genome has been built over many years of hard work and amazing scientific discoveries, from identifying the Mendelian inheritance through to the visualization of the chromosomes, the structure and sequence of DNA, the ability to clone an organism, and certainly, and most recently, the deciphering of the human genome. Saying this, there are many things that we probably misunderstand, and many more that we are still trying to understand. However, the basic principle is that our genome is unique for us. No one else had anything similar, no one else has anything similar, and no one else will have anything similar. This genome determines everything about us: our appearance, our personality, our health and disease status. This genome is represented in every nucleated cell in our body. It is the same genome. But if this is the case, how can we explain this? Why would different cells in our body that have an identical genome have totally different functions, although they all started from one cell? But also, how would an organism in part of its life cycle be a larva and at another stage of its life cycle becomes a butterfly, although it is still the same organism with the same genome? The reason for this was not fully understood until these two scientists made their experiments and discoveries. They didn't work together, but they jointly won a Nobel Prize. And these two scientists, through their work, they were able for the first time to take back a mature cell, take it back to its cell of origin, which is the pluripotent cell. So in a way, they reversed the process of development. And they did this by reprogramming this cell. They achieved this not through genetic changes, but rather through epigenetic modifications. So, what is the meaning of the word epigenetic? This is a process. It's a heritable process. So it is inherited from one generation to the other, that influences how our genes are expressed without any change in the genetic material itself. So the underlying DNA sequence is the same, but how genes interact and whether they become active or inactive is determined by this epigenetic mechanism. There are different types of epigenetic control. And the longer we carry on experiments, the more mechanisms probably we will identify. Some of these are not very well identified or not very well understood, and others are a little bit more understood. Because of the time of the talk, and more importantly, because I'm going to discuss the area of research I have been working on, I'm going to focus on a couple of these mechanisms of epigenetic control. The first one I'm going to talk about is something called DNA methylation. As we know, despite of the complexity of our DNA and genome, the DNA is just made of 4 molecules: adenine, thymine, guanine, and cytosine. As you all know, the adenine and thymine are joined together, and the guanine and cytosine are always joined together. However, in our genome, if there is a cytosine followed by a guanine, this cytosine can undergo a process called methylation. In our genome, in our DNA, there are certain areas where you get a cluster of these, what is called CPG, because the P stands for phosphate, because this is the bond that keeps the nucleotides together. And sometimes when you get these clusters of C's and G's, CPG we call them, this area is called a CPG island. And when you get methylation of many cytosines within this cluster of CPGs, the CPG island, this gene that is represented by these nucleotides can become switched off. So methylation of cytosine in the CPG sequence can cause gene silencing, and this is a method of epigenetic regulation. The other type that I want to talk about before I go into a little bit more detail is something called histone modification. Imagine that our DNA is quite long. So the actual length of a DNA strand in every single nucleus in our body is about 3 meters. Actually, if you stretch the DNA on a table, it would be 2 meters long. This is a DNA from one cell. I'm not talking about the DNA from all our body. Imagine how can you pack 2 meters of DNA within a nucleus of a small cell. Think about if you have a long thread or a long wire. What do you do if you want to pack it in a small drawer or something? You wrap it up. And histones are the proteins around which our DNA is wrapped up. Depending on how tightly this DNA is wrapped, the genes represented on this DNA can either be expressed, transcribed, or not. This histone, this protein, can also undergo a process of methylation. And if it goes methylation, this causes the DNA to be wrapped tightly, and this causes gene silencing. On the other hand, if it goes a different process called acetylation, the DNA is not wrapped so tightly, so the genes become easily expressed, whatever genes this cell wants to express. The important thing about this epigenetic mechanism or mechanisms is that they can happen at any time, but there are certain times in our life when our epigenome is very susceptible. One of them is obviously at the time of embryogenesis, when we are developing as embryos, still before even we become fetuses. There is also some epigenetic modification that can happen during neonatal development, around the time of puberty, and a lot of changes happen at old age. In fact, one of the very strong mechanisms behind the reason for aging that happens to all of us, unfortunately, is epigenetic. This is a diagram from one of our first publications on the issue of embryogenesis, gametogenesis, and the epigenome. And I want you to focus on this area, which I'm going to talk about later on. What happens to our epigenome is that in the very first few hours after conception, and I'm talking about hours, so this woman who is pregnant does not know she is pregnant yet. It's too early, just very few hours after fertilization. The epigenome of this embryo, of this developing fetus, gets totally wiped off. So the methyl groups get totally removed. They undergo a process of demethylation. And then, because of some epigenetic memory that is inherited from the parents, the remethylation happens again, and these cells carry on developing. So this seems to be quite a critical period of time. This applies to somatic cells. Germ cell lines have a different mechanism of demethylation and remethylation. I'm not going to go into the details of this, it's not relevant to our talk, but this happens actually at the time of the development of the gametes, so whether they're sperms or ova, the process of demethylation and remethylation happens at that time. So why am I bothering you with all this information? It does not sound as if it has any clinical relevance to us, but in fact it does. And one of the areas of focus of my research over the past few years was folate, folic acid. Folic acid is one of the B vitamins, it's B9. And folic acid is the most potent methyl donor that is known to us. It gives out methyl groups because folic acid is crucial in, if you remember from your biochemistry, the one carbon cycle, whereby the homocysteine, which is not a very nice substance in our body, gets washed out, changed to methionine, and this cycle carries on when methionine goes back again to become homocysteine. Of course, this is an oversimplification, but in this process, a carbon is released in the form of a methyl group. This methyl group is the methyl group we have been talking about. This is the methyl group that can go and attach itself to histones and methylate them, or indeed to the cytosine if it's next to a guanine and cause cytosine methylation. And because of knowing this information, which has been known for a while, we thought maybe we can assess if there is any correlation between the level of folic acid in maternal blood, in the fetal cord blood, and the fetal level of global DNA methylation, which is something that could be measured using some surrogates for measuring this without really going into too much detail. So we hypothesized that there might be a relationship between the level of folic acid in the fetal cord blood or maternal blood and what's happening in the baby's level of methylation in its genome. So we took maternal samples, cord blood samples after delivery, and in these cord samples, we looked at the fetal level of DNA methylation in the cord blood, which represents what's happening to the fetus, as well as the folic acid level in that. Unfortunately, we did not find any association between either the level of maternal folic acid or folate or the fetal folate and the level of DNA methylation. However, we found an inverse correlation between the level of DNA methylation and the cord blood homocysteine level. In fact, we were the first group to demonstrate this association. Of course, homocysteine level is representative of the efficiency of this one carbon cycle I talked about. It also is, in a way, a surrogate measure for the abundancy of folate. But saying this, we didn't really find the association that we hypothesized. What was more interesting, and this happened totally by chance, is that in one of the associations that we've identified, we picked up an association between the baby's birth weight and the level of DNA methylation, which in itself was really quite an interesting finding. It has been shown in animals before, but not in humans. Based on this, we did a little bit more sophisticated experiments looking not at global methylation, because global methylation is quite a rough estimate of the level of methyl groups within a genome. We started actually looking at the CpG islands I mentioned before. And we looked at about 7,000 of these in somatic cells using a process called high-resolution epigenetic profiling. And we've put the information from our experiments into a computer, and depending on the level of DNA methylation, it clusters the sample into those who have high levels of CpG island methylation and those who have low levels of CpG island methylation. The computer doesn't know what you're putting into the computer. It just does a mathematical analysis. And by this hierarchical clustering, it was able to, in a way, subdivide our sample into a group A and a group B. When we looked at group A and group B, they had very different birth weights. So this was another experiment that showed that the birth weight seemed to be not only related to the level of global methylation, but also what happens at very specific CpG loci on these CpG islands. This actually made us think, if, and this is the same diagram I showed you before, if this wiping off of methyl groups and the remethylation happens in the very first few hours of conception, then measuring folic acid at birth is really of no value. So it's not surprising that we did not pick up any association between the maternal or fetal folate levels and the birth and the level of DNA methylation. Of course, we can't measure the DNA methylation in a developing embryo or in a fetus, because yes, we might be able to do this in animal species, but not in humans for obvious ethical and the fact that it's not possible. But what we could do, we thought, we are going to look at the timing of maybe folic acid supplementation and its impact on fetal growth. You all know that folic acid has been introduced quite a few years ago and is now routinely recommended for anybody who's planning to get pregnant to reduce the risk of neural tube defects like spina bifida, the commonest of them all. However, for the folic acid to reduce the risk of spina bifida, it needs to be taken periconception, around the time of conception. In fact, the recommendation is that women who are planning to get pregnant should take the folic acid 2 to 3 months before they get pregnant to ensure that the level of folate in the system is high enough to achieve its effect when they are pregnant. I've told you that methylation and demethylation happens in the very first few hours of conception. So in our antenatal clinic, when you find somebody turning up to you who's pregnant, who's now 5, 6 weeks pregnant, you've just seen the fetal heart, everybody is happy and excited, and you say, take folic acid, this is too late if your intention is to reduce the risk of spina bifida, because the epigenetic mechanism and, in fact, the development of the neural tube itself has already happened. So it's a bit late to start prescribing this. I can tell you about what happens in the UK, because this is where I practiced for many years. Certainly, not many women, unfortunately, take pre-conception folic acid. And as many times, people blame the fact that the majority of, well, not the majority, but a lot of pregnancies are unplanned. I don't think this situation applies to Egypt. I'm talking about planned and unplanned. I think a lot of pregnancies in Egypt are planned. Certainly the first pregnancies are definitely planned. However, it will be interesting to know how many of these new mothers have actually taken folic acid beforehand. So going back to this hypothesis that if folate is linked to birth weight, and this might be working epigenetically, we could easily do a retrospective study and look at the outcomes birth weight wise of women who have had folic acid before the pregnancy and those who had it after the conception and those who did not have it at all. And this is indeed what we hypothesized. We hypothesized that the timing of when the folate was taken is or could be a determinant of birth weight centile. And fortunately, in the West Midlands region, we have something called the Perinatal Institute, and they have quite a large database of women, of everything that has happened to them during the pregnancy, and also the outcomes of their babies regarding congenital anomalies, and of course, birth weight and lots of other things. One of the pieces of information they collect is whether these women have had folic acid or not, and when they had the folic acid. And as you will see here, yes, the majority of women have taken folic acid. Some women didn't even bother taking it at all. But interestingly, out of the majority of women who have taken folic acid, the majority of them, the time was not recorded, so these women were not very clear as to when they started taking it. And a big number of them have had the folic acid after they got pregnant. So very few women end up following the actual recommendation of taking pre-conceptual folic acid. In the UK, if somebody has forgotten to take folic acid preconceptually, then they still actually advise them to take folic acid until they reach 12 weeks. I personally don't think this makes any difference because it's a bit late. But anyway, it's not going to cause harm, so people do it. When we looked at the outcomes of these pregnancies, you can see, and SGA here stands for small for gestational age. This is a lot of these babies will have some sort of growth restriction. You can see that women who did not take any folic acid, their risk of having a small for gestational age baby was much higher than those who took folic acid preconceptually. Post-conceptually, the risk reduction or the risk of SGA was not very far from that of not taking folic acid at all. And these figures are related to babies that are below the 10th centile. If you look at babies below the 5th centile, which is, as you all know, is a higher risk group of babies, again, with preconceptual folic acid, the risk of having a baby that is really quite growth restricted is much less than if these women did not take folic acid at all. And we're talking about a large study. This is a study that included more than 80,000 women. Using our data and undertaking a meta-analysis using data produced by other groups, we added our cohort to cohorts from other teams in different countries. And you can see definitely a significant reduction in the risk of small babies if mothers take folic acid pre-conceptually. However, if mothers take the folic acid post-conception, this line crosses the line of no effect. So there is no difference when it comes to the reduction in small for gestational age. These two observations made us conclude that supplementation with folic acid significantly reduces the risk of small for gestational age at birth, but only if this is commenced pre-conceptually. And this is independent of any other risk factors mothers might have. I want you to go back and think about this Dutch famine image. The problem has started because these babies were born small. Being born small could be an issue for the parents. Initially, they worry that their baby might make it or not, an issue for neonatologists. But once the baby develops and seems fine, everybody seems to be happy. It's a success story, and indeed it is a success story. But these children are still at risk of problems later on in life. Therefore, what is more effective as a public health intervention is to reduce the chance or the risk of babies being small in the first place. And I think ensuring preconception folate supplementation is something that can reduce this risk significantly. So when it comes to folating pregnancy, is it better late than never, as the English saying, as people say in England? Well, in this situation, the answer is no. Late is almost as good as never. So it's important, and my take-home message is important really to try and get young couples who are embarking or planning to have a pregnancy to at least be seen pre-pregnancy and be started on folic acid before they do so. And I'm here talking about maybe in Egypt couples who are about to get married in a few months' time. You know, one of the best gifts you can give them if they're going to plan a pregnancy straight away is a box of folic acid. So to summarize my talk, the epigenome is very vulnerable during the period of embryogenesis. Epigenetic changes that can happen can impact not only on our genotype, but also on the phenotype, if we think of birth weight, because this is a phenotype. These phenotypic changes could indeed be linked to diseases later on in life. And what's more important, and I mentioned this when I defined epigenetics at the beginning, these changes that happen, or changes that don't happen, depending on which genes get switched off or switched on, are passed from generation to the other. In fact, an epigenetic change that happens has been demonstrated in animals to be passed for at least 3 generations. There's an English proverb that says, "You are what you eat." I personally think that we are what our mothers ate. Thank you very much for listening.